Florida, in another one of our nightly Parkinsonism Hangout Education Series with Dr. Abdul Rana, world-renowned Parkinsonism educator from Toronto, Canada. Tonight, Dr. Rana is going to be lecturing on REM Sleep Behavioral Disorders and Parkinsonism, which I don't know what that means, but I guess we'll find out. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
Oh, oh man, oh man, oh man, oh man, oh man, oh man, oh man. I'm sorry, Dr. Rana. Okay, well, we'll continue on. A slight glitch there. Let me start off things with a question, okay? Are you okay, Dr. Rana?
Sure.
Okay, what is the common complaint of these patients with the REM sleep behavioral disorders?
Surprisingly, these patients themselves, they may have no complaint, and they are reported by their spouse, and the spouse would say that they were shouting in sleep, they were grunting, or they had a disruptive behavior, or they were trying to punch them. So patients may be enacting on their dream content, but patients themselves may not be aware in the mornings, and these are reported usually by the spouse of the patient, and therefore it becomes very important to take parallel history in these patients.
Okay, how are REM sleep behavioral disorders characterized?
Normal sleep goes through cycles of non-REM and REM sleep. So non-REM is the non-rapid eye movement sleep, and REM sleep is the rapid eye movement sleep. So this goes in cycles, and towards the late stages, the REM sleep starts becoming more prominent, and in these patients, so there is a loss of REM sleep muscle atonia. So when there is loss of atonia, these patients have involuntary limb movements or body movements and jerking and punching. So the activity of brain in these patients in that stage of sleep resembles more with wakefulness. So these disorders are significantly higher in patients with Parkinson's disease, and sometimes they could be present much before the other motor symptoms or other clinical features of Parkinson's disease. So if a group of patients with REM behavioral disorder are followed, a significant of them could develop Parkinsonism in future. So these patients usually have these movements which are involuntary, they have no control on them, and they are definitely more frequent in not only idiopathic Parkinson's disease, but other types of Parkinsonism as well.
Okay, are they seen with other types of Parkinsonism?
Yes, as I just mentioned, these type of problems are usually seen with idiopathic Parkinson's disease, but in addition to this, with other types of Parkinsonism, as well as synucleinopathies, these problems are also seen, such as multiple system atrophy or Lewy body dementia. And there is some evidence from the PET studies that there is a loss of the subclinical nigrostriatal neurons in these patients, and these patients may have olfactory dysfunction as well, the loss of sense of smell. So these patients not only have the REM behavioral disorder, but they have loss of sense of smell, and both REM sleep behavioral disorder and loss of sense of smell could be linked to the earlier stages of neurodegeneration in patients with Parkinsonism.
Very good. Any relation to hallucinations or dementia?
The REM sleep behavioral disorders were increasingly recognized in 1900 and mid-80s. And in these patients, since the activity of brain resembles more to wakefulness, so these patients do have association with illusions and minor or well-formed hallucinations, and therefore the RBD and hallucinations and cognitive dysfunction, they would evolve slowly with progression of motor symptoms of Parkinson's disease in the late stages of Parkinson's disease. Now, the presence of only RBD may not be sufficiently enough to predict the hallucinations or cognitive dysfunction alone, but as time goes, the probability of these problems increases in patients with Parkinson's disease or in patients who are elderly and they have greater motor dysfunction and executive dysfunction in addition to other symptoms of Parkinson's disease. The association between the REM behavioral disorders and cognitive dysfunction is also known in Parkinson's disease patients who have not yet developed dementia or cognitive dysfunction. So it could be taken as an early marker for the neurodegeneration, and there could be some structural lesions in the brainstem nuclei, which are involved in the pathophysiology of REM behavioral disorders. And there are some neuropsychological deficits in these patients with RBD, which could be related to the dysfunction of the cortical regions where there are projections from these brainstem nuclei. Now, the hallucinations are not only related to more severe cognitive dysfunction in these patients, but also the rapid progression along with RBD happens in these patients, and that could lead to increased morbidity or even high mortality.
Very good. How can one manage them?
The first step in managing these patients is taking a very detailed sleep history. And the sleep history, as we just discussed, should be taken from the spouse. A detailed sleep history, including the time of going to sleep, how much time they take to fall asleep, and then during sleep, how many times they wake up, and any abnormal behaviors. In addition to asking patient, asking the spouse is very important. And the spouse will give the details of their abnormal behaviors. Then once the history is available, these patients may need an overnight polysomnography for the recording, and they may need to be referred to sleep clinic in some cases. So we advise patients usually that if the spouse feels unsafe, so sleeping on a separate bed could be better. And also, if they have the railings of bed and high railings, that could avoid falling, because some patients could fall. And if there are any objects close to the bed, such as lamps or any nightstands which can cause injuries, so they should be moved away. The patient's bed should not be close to the window, and if there is such a space, then putting a heavy cabinet or a dresser might be safe in front of the window. And in addition, these patients should try to avoid alcohol, and they should always discuss with their physician for the possibility of treatment. They should never ignore this. And usually, once the sleep study is done and these patients have been seen in the sleep clinic and the diagnosis is confirmed, then certain medications could help, such as pramipexole in some cases. Otherwise, benzodiazepines, a bedtime dose might be helpful. Some experts do suggest a dose of melatonin could help these patients.
Very good. Anything else to add, doctor, before we close on this topic of REM sleep behavioral disorders and Parkinsonism?
Some patients may not want any treatment. So there are certain patients who don't want to take medications, or they feel that this is not causing them any serious issues. So in those patients, it's very important to emphasize the safety issues, that they should look at the environment where they're sleeping, and they should not get injured. Or if they fall out of bed, that could be very risky to them. So this is a very important component of addressing this issue: safety to themselves and also safety to their spouse. So if these two issues are addressed, and the REM behavioral disorders are not very frequent, they happen occasionally, and they don't pose any safety threat, so then these patients could be probably watched closely, but again, reviewing the history on every follow-up visit to make sure patients are safe is very important in this patient population.
Very good. Okay, so that wraps it up for REM sleep behavioral disorders and Parkinsonism. Thank you much, Dr. Rana, and we'll be seeing you in the next one.
So
Good night. Good night.
Good night.